and the popliteal artery. So it'd be an additional little injection that we do for total knee, basically. So he asked me to just talk about it a little bit, try and get people familiar with it. It shouldn't be a difficult thing to do, and you kind of have them already exposed in the right area with the adductor, so then it'll just basically be, you're coming down the leg a little bit further, kind of right above the patella, and looking with the ultrasound there and injecting behind the femur.
How is this different from what they're doing currently?
So, they inject kind of pericapsular wherever, and they all inject differently, and so some of them may be covering this fine, and some of them may not. It's kind of one of those, you watch them jab around with their local, some of them do a better job than others. So yeah, they could do this on the field, and basically, you can do this blind, like I did a few times in rescue, like it's rescue blocks. Basically, you hit the femur, you walk just off the femur and inject some local there, and that's the idea, is with their capsular injection, their cocktail they put in the joint, and their injection, that they should be covering this. That's why we typically haven't. So I didn't talk to Jeff exactly why there's some studies in their journals, in the orthopedic surgery journals, that show benefit with this and the adductor. So I'm assuming he saw some of those and wanted to pursue this. Because they're not going to change their injection. It sounds like they're still going to inject, at least from what I heard from Simon. And so we basically, I think right now we're doing 25 for the adductor with the 1/4%. Probably still do 15, 20 there, and probably just 10 behind the knee for this block. So there's several studies showing better range of motion, better post-op pain scores. Day 1, day 0 and day 1 afterwards, and they're small studies, but that's the idea of why he might be interested in this. And I'm not sure if it's going to spread to the other joint guys, but for the moment he's the one who's interested in it and wants us to start doing it. So that's why we're going to go over it a little bit. There's basically 2 levels they talk about. One is kind of at the level of the femoral condyles, and one's basically a finger breadth or 2 above the patella. And in either case, you're going to see, so the popliteal vessels are here. You're going to have your sciatic nerve basically lateral and posterior. And the idea is going to be, you're going to be coming medial, so you're going to have their leg, up or turned a little bit. Your probe's going to be here. I've got some pictures, and you're going to be basically coming down at a fairly steep angle to get kind of behind the femur here. And you want to be basically lateral edge of the popliteal vessels, because the goal is to not get it to spill into the actual sciatic nerve and get the peroneal nerve and get foot drop. If you go too far, potentially past, you can, some can spread that way. And that's why we're not doing a huge injection either. But the idea is it spreads to those little branches coming off that are innervating the capsule. Did you do many of these at Iowa?
I didn't. We were sort of discouraged. We saw some evidence that when you do an adductor canal block properly in some, there was one trial, one paper that I saw, that they're better because it's a targeted nerve block, and also you don't have the motor effect, which with this, a lot of times you can't, because you might hit the sciatic, like you said.
Yeah.
These are, you're not really, you're just, again, you're injecting sort of into the capsule. You're hoping that the intra-articular innervation will help. Yeah. But again, it's not a targeted thing, really. It's more of a...
And it's not going to last the same. It's, it's just like peripheral injection. It's a shorter duration.
And again,
not as reliable sort of.
The adductor, you're obviously more likely to have the motor sparing so that people can ambulate.
Yeah, with this, they should still be able to ambulate. The one thing is, if you get foot drop, that's the potential.
I'm just curious, you said somebody wants us to do them?
Jeff Goldstein. So he's the,
Yeah.
So he's the one who's asking for it. So yeah, that's why we're going to try and do a small volume injection back there and see if we can cover it. Again, the more important block is going to be the adductor, and then this is kind of put some local in between the artery in there and maybe they'll get a little benefit.
What about, I guess I have two questions. One is,
Yeah.
what is the evidence for this being better than the adductor for total knee replacements?
So there's a few, I mean, there's some stuff in some of the orthopedic journals,
Oh, okay.
and some stuff in, I think even ASRA. I was looking at it briefly the other day. So there's a few articles, there's a handful of articles in some of the orthopedic surgical journals. Some of them are like Indian studies, that there's one like International Orthopedic Journal. So they're not super high quality studies, they're not super big studies. So there's, a handful of articles basically showing, increased range of motion, decreased pain scores, day 0 and day 1.
Okay.
So it's not great evidence, there's some.
And I guess so it's in addition to the adductor, is that what you want?
Yeah, so it would be the adductor plus this. And that's what those studies are basically, we're comparing adductor versus adductor and Ipack. And that, the adductor Ipack being, significantly better in their studies, for reducing pain score and increasing range of motion, 0 to 1. So, I didn't go too much into the effectiveness, because, I don't know, more or less, he's asking for it, and there's not any huge downside to it. So I was mainly going to go with just kind of done.
I read a study that they did at University of Iowa
Where they compared adductors and intra-articular injections. They weren't IPACs, but they
Yeah.
just injected essentially the same thing. And it wasn't significant, but the adductors were better in terms of pain scores.
So you're talking about doing just adductor or just intra-articular injection?
Correct.
Yeah, and that's clearly going to be the
And
case. Then that's been shown, that the adductor is the block to do for knee replacements, and it does help.
Can you show us how to do
Yeah.
it?
So positioning, so you're already kind of in that position. Propping up their leg a little bit is going to be key to kind of getting the leg a little externally rotated and up, so you can get on the medial side. So he's standing lateral, and then you've got the probe medial, and basically you're trying to get a picture. You're down posterior enough on the leg that you're going to get a picture of the artery and see your needle coming in at a pretty steep angle. So this is going to be kind of the ultrasound picture you're going to get. You're basically looking for the femur, and then you want to try and find the popliteal artery, posteriorly there. So probably putting on some color, something like that will probably make this easier, because it may not be a very super well-defined, circular structure like we see for some of the other blocks. And so this is the anatomic image behind. So you've got vessels here, which is what this is here, and then you've got your sciatic nerve back here. So that's why ideally you're coming right kind of along the femur, because you're going to be coming from here. This is going to be your anterior side. You're coming down steep, kind of right up next to the femur. And the goal is to just inject the local in between the artery and the femur, and trying to be middle of the artery, the posterior part of the artery would be kind of as far as you really want to try and go with the injection. And this is kind of the anatomic and, again, positioning. So it's a very steep angle you're coming in at, in plane, anterior to posterior, basically trying with enough of an angle just to get posterior to the femur. And then these are going to be your vessels. So again, this is just a different kind of angle of that image.
And you're just above the kneecap?
And just above, yeah. So this is, you can do it at the level of the femoral condyle. So if you feel that, you can do it there. That's a little bit more distal. You can also feel kneecap and go 2 finger breadths above is the other place, and that's a little bit more proximal. So somewhere in that region is where you're going for this.